Hello, welcome to this talk about mask ventilation titled The Art of the Squeeze. Okay, take a second and picture this. A patient is under anesthesia, and for a few critical minutes, their ability to breathe is literally in your hands. Not with a fancy tube, but with this a simple face mask. It seems straightforward, right? But as we will see, effective mask ventilation is less about force and is more about physics. Let's break it down and see how to master this fundamental skill. All right, so this is our standard face mask. It's a disposable dome with a cushioned seal and a connector to a breathing tube. Our job is to use this to do two things simultaneously. Number one, create an airtight seal between the mask and the patient face. And number two is to ensure that patient upper airway are open and the airflow in and out. So fail to seal and all the air you push is just gonna leak out, making a funny whistling sound that is not helping your patient. Fail at patency and you are trying to blow up a balloon that is knotted in the middle. You will just inflate the stomach and no one wants that. So how do we actually hold this thing? Many of us learn the C and E technique. The C is your thumb and index finger presses the mask down to create a seal, and the E is your other three fingers lifting the jaw forward, which is our first airway maneuver. It's a good start, but it has its limits. With only two fingers, the mask can leak, and especially on the side of opposite to the thumb, so you have to seal it this way, but sometimes you need more power. So this is where you level up, and for a better seal and a more airway patency, we go to the two-handed technique. So if you put your both hands, you will be able to do a better jaw thrust and head extension. See the difference? Fantastic. So seal with one hand and then do a jaw thrust with two hands. And if you have another helper, they can squeeze the ventilator for you and they can back for you. Now, let's talk about what can go wrong. Mask ventilation is a dynamic process. Obstruction can happen on the in breath or the out breath. On inspiration, the big culprit is often the tongue. So if the tongue falls back, it's going to obstruct your flow. The fix, a oropharyngeal airway, it's a props. It props the tongue forward and commits us to breathing through the mouth. On expiration, the sneaky villain is often the soft palate. It can flap and shut as a one-way valve. So you will see the chest rise but no fall, and we call this pressure stacking, and the pressure builds up, and once you put the mask off, whoosh, again just of air goes out, and oropharyngeal airway is a fix for that too because it helps that soft palate open. So your troubleshooting technique is simple. If ventilation is poor, first optimize your position, get the patient sniffing, and switch to two-hand technique, and then after that you can use your adjunct. Don't shy away from them. Early use of oral airway is a key. Finally, how do we know we are doing a good job? We look for objective signs. We want to see a nice square root capnography. That is our proof that the gas is going in and out. We want a low airway pressure, about 20 centimeter mercury, to avoid stomach inflation because the pressure of the lower esophageal sphincter is about 15 to 20. We want to see a soft chest rise and fall, and don't just give volume and push hard. Work with strategy and make sure that you're doing well. So key summary points: the two pillars, perfect your seal and ensure airway patency. Technique is a key. Master two-handed technique with a jaw thrust for difficult cases. Use your tools like oral airway. They are your best friends for relieving soft tissue obstruction. Measure your success. Aim for good capnography, low airway pressure, and visible chest movement. Remember, in anesthesia, the most advanced tool in the operation theater is often a well-trained pair of hands. Thank you for your time.